Delighted to welcome virtually Dr. Anitha Vijayan here today. Unfortunately, she wasn't able to travel due to the delays at the airports these days. It's really a pleasure to welcome Dr. Vijayan here. She's a nationally and internationally recognized leader in nephrology. She currently serves as Senior Medical Director for Intermountain Health Kidney Services, where she oversees kidney care across a six-state enterprise. Before she transitioned to her current role, she was a professor of medicine at Washington University in St. Louis till October 2023. She also was the medical director of acute dialysis services at that health system and served as the nephrology subject matter expert across the health system. Prior to doing her training at Washington University in St. Louis in nephrology, she actually received her medical school degree from University of the West Indies in Kingston, Jamaica, did internship and residency in the Bahamas, and then internship and residency at St. Luke's Hospital in Missouri. She has played a pivotal role in shaping the national nephrology policy, including a very important effort from the American Society of Nephrology in response to the COVID-19. And more recently, she chaired the ASN AKI Recovery Work Group. As the work group chair for this work group, she is a lead author on the ASN guidance for patients with dialysis requiring AKI, which is something we'll hear about today. At Intermountain Health, she works on more than just AKI, and she has made significant strides in improving access and care for kidney patients in the hospital and outpatient setting, partnering with primary care, critical care, hospitalists, pharmacy, and other teams across the system. So thank you very much. We're delighted to hear from you today.
Thank you, Dr. Isakova, for inviting me and for the kind introduction. It's truly a pleasure to give this grand rounds. It's truly an honor. I wish I could have been there in person. Chicago is one of my favorite cities, so maybe another time. But yeah, for today's talk, I will be talking about caring for patients with acute kidney injury in the outpatient dialysis center. And as you can see, I titled this talk "The Road Less Traveled," as opposed to the road not taken by Robert Frost. This is actually road less traveled because very few people are aware of the care of what it takes to care for these patients in the outpatient dialysis setting, because of the few people that actually have to go to the outpatient setting instead of the traditional ESRD patients. So these are my disclosures. I do consult for dialysis companies, but they are not relevant to this talk. I don't try to keep anybody on dialysis any longer than I have to. So I'm going to start this presentation with a few cases that have shaped my career and also my interest in this particular area. And I still remember this vividly from my fellowship, more than 20 years ago. This 72-year-old lady came to the hospital when I was on consult service and essentially was quote unquote ESRD patient on her way to dialysis in a rural area in Missouri. And on her way to dialysis, she had a motor vehicle accident, ended up with a splenic laceration, a femur fracture, so airlifted to our tertiary care center. And when I talk to her, I always ask patients, even if they have ESRD, how does dialysis go? How does your outpatient dialysis go? Do you have any symptoms during dialysis? Do you have hypotension? What medications are you on? And she told me she has to get up regularly in the middle of dialysis to go to the bathroom to urinate, which is, pretty much unheard of in our ESRD population. And she also, interestingly, had an AV fistula in place. And then when I discussed this with my attending, he said, "Oh yeah, I had to help her off the bedpan. She had made a lot of urine when I saw her." So what I did was we held dialysis, and then of course she went through her splenectomy and her femur fracture repair. And then I did a 24-hour urine collection, and she had a creatinine clearance of 12. 12, you think, oh, it's low, but that's okay. People can still function, off dialysis with 12 ml per minute, as we know in our CKD world. So I continue to hold dialysis and advise patient not to go back to dialysis. Repeated creatinine clearance a few months later, it was 17, and she continued to follow up with me for 3 to 4 years. High quality of life. She loved to do her riding lawnmower and work on her yard, and she continued to do that and never needed to restart dialysis. So this tells me, A, why was she labeled as ESRD? We can get into that later in the conversation. And two, she already had an AV fistula placed. And again, probably because she had been diagnosed as having ASRD. We know AV fistula is not a benign thing long-term. Then my second case happened during the ATN study, for which I was the investigator at WashU. And this patient was discharged home to Arkansas after the AKI. And as the study coordinator contacted the patient or called to get labs from the patient from the dialysis center, she noticed that the pre-hemodialysis potassium was 3, phosphate was about somewhere in the 2s, and the creatinine was also relatively low at 2. And when she called the patient said, "Oh yeah, I'm making lots of urine." So I picked up the phone and called the outpatient nephrologist, and I said, "Hey, I think the patient is recovering." And he basically said, "I'll do a 24-hour urine to assess clearance." And then when I suggested stopping dialysis instead, he was not happy with me and threatened to report me to my division chief for whatever reason. But this also points to the fact that no one knows how to get patients off dialysis, right? Is it a taper? Do you stop cold turkey? And so there's a lot of unknowns yet on how we manage patients in the outpatient dialysis center. And then, of course, a lot of you may have heard Marla Levy's story. This is from UCSF. Patient underwent a complicated cardiac surgery and ended up on dialysis in the hospital. And she was discharged to an outpatient dialysis center. There was no communication, according to her, between inpatient and outpatient dialysis. She continued to get dialysis 3 times a week, was told she'll never recover, needed a kidney transplant, and then she was referred for vascular access. And the surgeon who saw her said, "Hey, maybe you should get a second opinion." So she went to Dr. Chi Su, who reviewed everything and essentially stopped dialysis. And Marla is so grateful for that, because who doesn't want to get off dialysis, right? And she, in her words, "I didn't believe it. It was like being told I had won $100 million in the lottery. Best news of my life." And she goes and speaks. She's a huge patient advocate for patients with AKID. So these are some of the patient stories that are behind what I'm going to show you today. So I'll cover some of the epidemiological data and the transition from inpatient to outpatient dialysis. What are some of the things we can do to promote renal recovery? What are the policy and regulatory gaps in the US, and some challenges and opportunities? So as you know, AKI affects 20% of people in the hospital, maybe slightly higher, but the percentage that needs dialysis is actually much lower, right? Only about 1 to 2% of patients may end up on dialysis. And of that, there's about 50% mortality. So the patients who are discharged is actually a very small number. And renal recovery for these patients usually happens within 90 days. But having said that, we've all had patients who may have recovered renal function even after 90 days. But for Medicare purposes, and most of the literature suggests 90 days is kind of that cutoff where you make a decision. Is the patient going to transition to ESRD or AKI? And according to this, of those that are left at maybe 90 days, 40 to 80% are labeled ESRD, and 1 to 6% can even recover after 90 days. More recent data from USRDS, patients in the hospital, about 4% of patients in the hospital require dialysis for acute kidney injury. And if you look at the transit, when you put in the outpatient setting, we know the prevalence of ESRD is about 500,000 in US. And if you overlay the AKID numbers in the outpatient setting, it's about 15,000. It's probably a little higher because remember, this is only Medicare data, and more often it's the younger people that get AKI compared to ESRD. But again, the point being, it's an extremely small number, but a very vulnerable population. And this is USRDS data showing kind of that recovery that I was telling you about. So patients in the first month, about 60% of those patients remain on dialysis for AKI. By month 4, it's about 9%. So either they're recovering or they're transitioned to ESRD by about 3 to 4 months. This is Fresenius data. They looked at all comers in their dialysis centers. This is data from 2019, and 20% of admissions have AKID. So a pretty decent number. And then when they looked at the outcomes of the Fresenius patients, most of the renal recovery happens by 90 days. So 36% of patients had recovery at 90 days. And if you look at 150 days, it's 38%. So that 2% still can recover later, but most of the recovery happens by 90 days. Why do we worry so much about these patients? So AKI patients are not ESRD patients. These patients have usually have just been in the hospital for sepsis or major cardiac surgery. And their mortality after they transition to outpatient dialysis is significantly higher than your ESRD patient in the first 2 months. By 90 days, my third month and fourth month, the mortality kind of is equivalent to those patients with ESRD. So this first 2-3 months are extremely important in how we care for these patients. The risk factors for persistent AKI, this is a smaller study by Javier Neira at University of Kentucky. And essentially, older age, more comorbidities, lower GFR at baseline, and somehow more blood transfusions. But I guess that just denotes how sicker they are. So this, again, tells you why these patients have a higher mortality in the outpatient setting. And this is a nice figure from Seda Babarudi's paper that was published in JASN last year. It's a review paper on this AKID. And you can see how she went through each part of the risk factors for non-recovery or risk factor for higher mortality. Social determinants of health have been shown, intradialytic hypotension, net UF, and I'll come to this later in the talk, medications, and of course, patient factors that I just mentioned. So all this background data led to ASN. As you know, last year, ASN decided to have guidance documents on certain key issues that affect our kidney population. The first one was obesity and CKD. And the second one was they felt this topic was so important that they decided to have the second guidance on dialysis requiring AKI. And Mike Hung from University of Michigan and I were asked to chair this session. So I'm going to start with transitioning patient from inpatient to outpatient dialysis facilities. And I know there are fellows in the audience that I'm not able to talk to you, but right now I know that if we'll come back to that. Right now, if you were to transition a patient from your acute dialysis setting to one of the dialysis centers somewhere, it could be Indiana, it could be just down the street, there's no good way for you to communicate any information to that dialysis centers. We still rely on fax machines to fax information, and we have no idea where it ends up. It could be in the unit secretary's fax file. We have no idea who reviews this information. So we really lack in communicating appropriately with the outpatient dialysis center. And so our recommendation as part of this was that we really want a warm handoff. I know this is great, when it's individual patient. This is not ideal for population health science, but at least for that individual patient, we are recommending a warm handoff. Find out who that accepting nephrologist is. Pick up the phone and call them, or better yet, find them in the physician's lounge if they're at Northwestern, and just talk about this Mr. Smith, who is coming to the outpatient setting. Explain the diagnosis, comorbidities, prognosis for recovery, what their goals of care are, right? So as the treating physician in the hospital, we know what the wishes of this patient was before they ever went on dialysis, right? And so if a lot of patients, you put them on dialysis, they don't have the knowledge or maybe the strength to just even ask, hey, doctor, can I come off? Or do I have to stay on this forever? Maybe they don't want a long-term dialysis and they're too afraid to say that. And so if we know what their goals of care are, we should communicate all that to the outpatient nephrologist. So, and of course, any complications during dialysis, any increases in urine output, all of this should be transmitted. So let me go back to this table that we have in the guidance document. So what we said was we're going to make a best guess on what the recovery phenotype is, educated guess based on all the information we know to date, because there's no good stratification model on what recovery looks like for patients with AKI. So we classify the patients, or we're recommending classification as high, moderate, and low, depending on what their prognosis for recovery is. And this is important to communicate to the outpatient nephrologist so they can monitor for renal recovery. So the younger patients, so somebody who just had a motor vehicle accident, had rhabdomyolysis, we expect them to recover, right? So that would be important information to transmit. Somebody who already had stage 4 CKD, had major complication post CABG, less likely to recover, right? Especially if they're older age. So, and this is important because as much as we want everybody to be assessing for renal recovery, if there's no good, if there's no reasonable chance for them to recover renal function, you can transition them to the ESRD diagnosis earlier. And this will have implications on their benefits, Medicare benefits, and other things. And I'll touch on that a little bit later. So that's warm handoff. And then, of course, this is the clinical care pathway that we discussed. Patient is ready for discharge. We offer the patient education and psychosocial support in the hospital. We estimate their recovery phenotype, and then we hand them off. And then, of course, in the outpatient setting, we're recommending that they be introduced to the interdisciplinary team, ongoing AKI-specific education, psychosocial support. Their needs are different from an ESRD patient. And then, of course, medication reconciliation management. And we're recommending active medication reconciliation, which usually doesn't occur in the outpatient ESRD world. So how do we care for these patients in the outpatient setting? So for a patient with end-stage renal disease, we don't expect renal function recovery. There's no reason to monitor their urine output. Labs are usually checked monthly, maybe hemoglobins are twice a month. Ultrafiltration per session, usually a dry weight is set, and the nurses or techs target towards that. Hemodialysis prescription, hardly ever adjusted, maybe monthly. There are clear protocols for bone and mineral disease, anemia, blood pressure targets. It's not being adjusted on a regular basis. Of course, we want everybody to have a fistula or a graft. And so general approach is protocol-oriented ESRD care. Well, AKID patients are different. We're expecting renal recovery. We would like to have urine output at least documented weekly, or 24-hour urine creatinine clearance completed weekly. We strongly feel they should not have a dry weight. Ultrafiltration targets should be adjusted per session, similar to hemodialysis prescription. We may need to be able to wean them down. We have no idea if there should be even any treatment goals for bone and mineral disease and anemia. Blood pressure target should be actively managed, since hypotension is a big, leads to further ischemic injury and delay in renal recovery. And of course, we expect them to have catheters. And essentially, the goal for patient with AKID is more individualized care. So for patients with AKID, we are recommending continuous monitoring for renal recovery. And depending on the phenotype, we're expecting them to recover between, anywhere from 30 to 90 days. And if they don't recover by 90 days, that's when you would usually transition them to ESKD. Like I said, you can transition patients early if needed. So let's talk about dialysis liberation. And in fact, this is a word that's been used more commonly lately, including in this Liberate-D trial, which I'll touch on. But actually, we got some, we got a slap on our wrist when we put this in the guidance document, because they're like, oh, liberation means, release from slavery or whatever, and dialysis is not slavery. It's very true. Dialysis is a life-saving procedure that we should all be using appropriately, right? But for a patient, being stuck to a machine 3 times a week or more frequently can still feel like they're, caught in a prison or whatever it is. And so I kind of continue to use the term dialysis liberation over dialysis independence. So for the fellows in the room, I wanted you guys to start thinking about recovering from dialysis or recovering from AKI way before the patient is ready to be discharged. I want you to start thinking about how we can do better dialysis in the hospital, even timing of dialysis, because we know the timing of initiation, higher doses, more frequent dialysis, and higher UF rates all delay renal recovery. So let me show you some of that data. So this is a START AKI trial, which most of you are familiar with, multinational AKI trial with over 3,000 patients. And essentially, it was looking at when do you start dialysis in patients with AKI. And the patients who started dialysis as soon as the AKI was diagnosed without waiting for specific indications, they obviously got more exposure to dialysis, right? Well, when they looked at RRT-free days at day 90, if the standard arm had higher RRT-free days with the odds ratio of 2.62. So we know that time on dialysis can potentially delay renal recovery. What about initial RRT modality and outcomes? So for a long time, there were a few head-to-head trials looking at CRRT and HD in the 90s, lower quality, fewer numbers, and nobody has bothered to do a larger randomized study since then. However, we have some information from the post-hoc analysis from the START AKI trial. So patients who were started with CRRT as the initial modality tended to have less RRT dependence at 90 days compared to those on IHD. And this was statistically significant. Again, this was a pre-specified post-hoc analysis. And then odds ratio of 0.61. And then this data from Jay Coyner and Javier Nera looked at patients in a real world data. This is about 38,000 patients. Again, retrospective data, but looked at CRRT initiation versus IHD initiation as the initial modality. And again, patients who were started on CRRT as the initial modality tended to have less RRT dependence at hospital discharge, even if they had 1 RRT or 2 RRT sessions. What about ultrafiltration? So this is data from Mike Hung that looked at patients who had ultrafiltration rates in AKID, and higher UF rates were associated with delay in renal recovery, okay? And this is also shown in that Fresenius data as well. The higher the ultrafiltration, the urine output tended to have a negative correlation. It could be that they were ultrafiltering more because the urine output had dropped off. This is all retrospective data, but there appears to be a correlation. And we have seen this in practice as well. You dialyze somebody today, ultrafilter them, next day the urine output is much less in the hospital. So we've seen this yo-yo pattern as well. What about frequency of dialysis? So this was a retrospective, this was a post hoc analysis of the ATN study where we looked at patients who only received intermittent hemodialysis. So we excluded everybody who got CRT and HD, and the incidence of renal recovery in patients who were on the less intensive strategy was higher. Intensive strategy was 6 days a week, less intensive 3 days a week. So yeah, the recovery was higher in less intensive strategy. So I always have told people, well, we don't need to dialyze people more than 3 days a week. You can have ultrafiltration, extra ultrafiltration sessions if you need it. But this led to the more recent Liberate-D trial, which was a late-breaking trial presented at ASN, led by Kathleen Liu and Chi Su. And essentially, we randomized 200 patients to conservative dialysis and or conventional 3 times a week dialysis. And so this is conservative dialysis. So this is the AKI trial initiation criteria they used as the criteria to continue dialysis. Okay, so BUN greater than 112, hyperkalemia, or K greater than 6 or 5.5 despite medical treatment, acidosis, acute pulmonary edema, and clinician judgment. And then in the control arm, we continue dialysis until, so 3 times a week until the creatinine clearance was greater than 20. We could use our judgment if clearance was between 8 and 20. So a lot of people stop dialysis if the clearance was 8. Urine output greater than 1 liter a day without diuretics, greater than 2 liters a day with diuretics, or a spontaneous drop in serum creatinine by 0.3 over greater than 12 hours. And the primary endpoint, there was improved kidney function recovery at hospital discharge in the conservative arm, 64% versus 50%. And you know, this, of course, this was unadjusted, but there's this can be viewed as a pivotal trial which needs further validation in a larger trial. But all of this points to the fact that more frequent dialysis, longer exposure dialysis, more intense dialysis, and aggressive ultrafiltration all lead to delay in renal recovery. And we have coined this as dialy trauma, kind of equivalent to the Venn trauma that we talk about, right? And so we have to think of dialysis as a life-saving measure, but also potentially harmful if we don't manage it appropriately. So talking about outpatient management, Ian McCoy looked at the satellite dialysis center and kind of compared the prescription of an AKI patient versus ESKD, and everybody got 3 times a week dialysis. So if you're sending a patient out who's making 1 liter of urine, do they really need 3 times a week dialysis? I would argue no. But right now, there's no good way to create an order set in the large dialysis organization specifically for AKI. We just transitioned to Epic here, and so we own and operate 7 dialysis centers, and so we made sure we have an order set for outpatient dialysis specifically for AKI, which addresses some of the things that I discussed. So from the ASN guidance document for promoting renal recovery, we are recommending, or we can't say recommending, we're strongly suggesting, avoid setting a dry weight or target weight, assess volume status every treatment, and it could be the nurse calling you with a volume status assessment. I know it's hard to round on everybody every treatment. Adjust ultrafiltration goals accordingly. Some patients may not need any ultrafiltration. Wean down dialysis treatments with increases in urine output. Using high-dose loop diuretics, extremely important. If your patients start to make urine, give high-dose loop diuretics. This has been shown in ESRD by Jenny Flythe as well. This will prevent that volume overload. And of course, stopping and tapering dialysis early. 24-hour urine, again, this is from Ian McCoy's data. For some reason, incident ESKD patients were also having 24-hour urine collected there, but only 28% of AKI patients in satellite had 24-hour urine collection. We are strongly suggesting that every AKI-D patient have 24-hour urine collection at least once a week to measure their creatinine clearance and maybe even urea clearance as well. We are also suggesting weekly pre-hemodialysis creatinine. And in our flow sheet here in EPIC, we actually have a spot for the nurses to chart urine output. So it's a matter of asking how many cups of urine do you make in a day, right? And the RNs can potentially convert that into mLs and put it in the flow sheet. Because if you can see a steady rise in the urine output, that is the first indication that the patient is recovering. Stopping and tapering dialysis, no criteria. ATN study used creatinine clearance of 12. The Liberate-D trial used 8 ml per minute. So I would argue that if the creatinine clearance is getting to 8 ml per minute in the outpatient dialysis, it's time to at least hold dialysis or taper dialysis. Ideally, you could just decrease the duration of each treatment if the patient tends to have volume overload, or you can reduce the dialysis frequency. Anemia management, I don't want to take too long on this, essentially because there's no evidence on how you manage anemia for AKI-D patients. We just made general guidance that if the patient is RRT dependent greater than 4 weeks, we would suggest starting EPO and keeping targets similar, hemoglobin targets similar to ESRD. And of course, you treat iron deficiency with IV iron as you would do in the general population or ESRD population. Bone and mineral disease, this is where probably our statements are a little stronger. Of course, treating vitamin D deficiency patients leaving the hospital after critical illness tend to be vitamin D deficient. We are more concerned about hypophosphatemia in this population than hyperphosphatemia, since they tend to be malnourished. And we made a bold statement to avoid phosphate binders unless the phos is severely elevated for greater than 4 weeks. Phosphate binders are the absolute worst pill you can probably ever take. I don't know if Northwestern does this, but at WashU, we used to have the fellows taste phosphate binders as part of their outpatient dialysis rotation, and they're nasty. I've tasted them myself as well. So why would you give a sick patient who just came out of the hospital phosphate binders for a phosphorus of 6? There's no data that controlling phosphate in the immediate setting improves outcomes. So we suggested equal or greater than 8. And of course, we don't recommend starting cinacalcet, calcitriol, other treatments for secondary hyperparathyroidism unless they've been RRT dependent for 4 weeks because of lack of data in the AKI population. I'm not going to touch on adequacy. Medications, we don't have a pharmacist in our outpatient dialysis centers. Nobody has, as far as I know, but we did have a pharmacist in our guidance document, committee. And, we really worked with her to understand what medication management should look like in the outpatient setting. And maybe that's something to, push for legislative change, have a pharmacy support for our outpatient dialysis, not just AKI, but also ESRD patients. We did recommend starting ACE or ARB early, provided there's no concern for hyperkalemia if the patient is in the recovery phase. Data on reinitiation of SGLT2 inhibitors is scarce, but there is some data suggesting that even in ESRD population, it may have cardiac benefits, but not enough for us to recommend anything. And then we also created a nursing checklist for the nurses to understand. So in outpatient dialysis world, right, the nurses and techs go through a 6-week training period, maybe a 3-month training period, and they're taught everything about ESRD. A lot of nurses and techs do not understand the difference between ESRD and AKI and why it's important for us to monitor urine output, why it's important to avoid hypotension. So we created a nursing checklist and also encourage nurse education as part of this work. So patient can either become independent or liberated from dialysis or transition to ESRD. And again, once they achieve that dialysis independence, we need to make sure that same warm-off happens as they transition back to a kidney clinic, because these patients are high risk for CKD, even if they recover to eGFR of 70, 80, we know that data shows they're at high risk for CKD long-term. Timely transition to ESRD is extremely important because the ESRD Social Security and Medicare benefits do not apply to AKI patients. The number one is like transportation. The other thing is AKI patients have just lost their job, or they're at the risk of losing their job because they're not able to work. There's no benefit from the Medicare side to help these patients. And so if you think or you feel strongly the patient is not recovering renal function, we need to transition them to ESRD and plan for long-term dialysis, either home or in-center hemodialysis. And then, of course, you cannot refer a patient to transplant if they have AKI. So make sure we keep this in mind. So what's some of the policy and regulatory challenges in outpatient care? And I hope I'm staying on time. Yes. So again, this would have been a question for the fellows. So 67-year-old patient, this is in February 2016, note the time. Baseline serum creatinine is 1.9. Patient develops AKI, start on CRT, then transition to HD. Day 10, patient is ready for discharge, but remains dialysis dependent. What option did this patient have for outpatient dialysis? I don't know if some of the attendings who would know the answer to this probably. So just to follow up, there was no option, or there were minimal options. And the reason I show this document, and this is called Form 2728, again, for the fellows, I know all the attendings are familiar with this. This is the document that every nephrologist have to sign for a patient to be admitted to the outpatient dialysis center prior to 2017. And this one essentially says that the renal impairment is irreversible and permanent and requires a regular course of dialysis or kidney transplant to maintain life. This is a legal document. It goes back to Medicare, and you have to sign this. And so for a patient with acute kidney injury, I never felt comfortable signing this, but I know a lot of physicians probably have had to sign some version of this document to get the patient out of the hospital prior to 2017. And in 2017, as part of the Trade Act, for whatever reason, AKI, this ruling was passed where patients with acute kidney injury could be treated at outpatient ESRD facilities in the United States. And there was some language about the payment models and everything. But interestingly, they never talked about what quality metrics we should be tracking, how to care for these patients. Basically just said, yes, now these patients can be taken at outpatient dialysis center. In 2025, they improved on this, and essentially starting January 2025, they will approve home dialysis. So between 2017 and 2025, if a patient had to go to a nursing home, you couldn't discharge that patient because nursing home was considered home, and patients could not be discharged on PD. This happened a lot during the COVID pandemic because of this, the prior ruling only covered in-center hemodialysis. Should we do PD for AKI just because this exists? Maybe it is associated with less dialate trauma and increased likelihood for renal recovery, and of course can be done at home with adequate support. Of course, the cons is, you require another surgical procedure for if you're going to recover in 4 weeks. Should we put the patient through that? Patient had various GI issues during hospitalization. Training will take time, so it takes about 2 to 3 weeks for the PD catheter to heal, then training. And so that again may not be worth it if the patient is on a road to recovery. And patient is debilitated, may need help at home, and of course concern for malnutrition and hypoalbuminemia. So I think it's helpful that we can do dialysis at home for AKI, but you have to do careful patient selection. Billing and coding. So patients in the outpatient setting who are on dialysis for AKID, you don't have the monthly comprehensive note because they're not ESRD. So the comprehensive notes and the once a week visits that you get reimbursed for is only applicable to ESRD. If you see a patient with AKI every time they're on, that is a billable procedure with a 90935 code. So what are some of the things we talked about as research priorities? So obviously we really need to figure out how can we improve or promote renal recovery, right? So preventing hypotension, preventing dialytic trauma, that's something that we should be focusing on. Investigating whether, maybe we should do a randomized controlled trial even in the hospital, PD versus HD. There's data from Thailand and other countries showing that PD is definitely associated with improved renal recovery, but probably needs to be a larger study. Identify optimal hemodialysis cessation strategies. Should we wean people off? Should we be doing a diuretic challenge early? Again, a lot of unanswered questions. Characterize optimal hemoglobin targets, and we also lack data in pediatric patients, and the pediatricians on the committee felt very strongly we need additional research here. So to summarize, the current care model for patients with AKID is kind of like this. In fact, I just put the red chairs and the blue chairs. But, we don't even know when you walk into a large dialysis center who has AKI and who doesn't. Nurses could have 8 patients in their pod. They have no idea of knowing who has AKI, right? So right now, the patients are all scattered all over the dialysis center. They're not easily identifiable. We don't have specific order sets for AKID. And they're receiving the standard protocolized care in most facilities. We also don't have any recommendations regarding how often these patients should be evaluated. No guidance on monitoring for renal recovery, and of course, we don't even have a change in nursing ratio for AKID patients. I think the current nursing ratio in the outpatient dialysis is probably 1 nurse for 8 to 12 patients with a couple of techs. So one thing that we are strongly suggesting is maybe, cohorting these patients somehow, clearly identifying patients in EMR, patient and staff education, higher nurse to patient ratio, AKID specific order sets with weekly monitoring, and a pharmacy guided medication review and management. So to summarize, again, small, highly vulnerable population, they need specialized care in the outpatient dialysis facilities, focus on dialysis liberation, so promoting renal recovery and getting them off dialysis. And I'd like to thank my colleagues on the AKID committee, as well as the Liberate-D team led by Dr. Kathleen Liu and Chisu at UCSF. And thank you all for listening.
Terrific. Thank you so much, Anitha. That was really a very comprehensive summary, and you nicely outlined all of the issues. I guess I'll start with the first question. Seems like a very obvious solution is to separate the patients, as you showed towards the end.